hearing from Dr. Nadine Shehata, who is a hematologist at Mount Sinai Hospital in Toronto, focusing her practice on maternal hematology. She is also the head of transfusion medicine at Mount Sinai Hospital, which is the largest maternal fetal center in Canada. She is a full professor in the departments of medicine, laboratory medicine, and pathobiology, and has an appointment at the Institute of Health Policy Management and Evaluation at the University of Toronto. And Nadine is going to be speaking on the issue of data integrity. So Nadine, the floor is yours.
Thanks very much, Jacob. My disclosure slide, and this is relevant because I'm going to be discussing trials that were actually funded by CIHR, Canadian Blood Services, and Health Canada. I have one objective for the next 30 to 40 minutes or so is really to describe facilitators for completing a study or trial with data really of high accuracy and validity. And I'm going to focus on trials, but obviously some of the concepts are going to be the same for any kind of research. I have one disclaimer as well. There are definitely going to be slides that will be evidence-based, data supporting what is done to ensure data integrity, but some of those slides are going to be based on my experience with the TRIX trials. So I just want to briefly describe the TRIX trials that I will discuss throughout the slide as an example of ensuring data integrity. And there are 4 TRIX trials. Essentially, they're all looking at restrictive versus liberal transfusion strategies, red cell transfusion strategies in patients undergoing cardiac surgery. The first one was 50 patients at a single center, St. Michael's, that looked at adherence and enrollment. The second one was a multi-center pilot feasibility study that also looked at adherence and enrollment. Those patients actually were subsequently included in the TRIX-3 trial, which was published, I think, almost 5 years ago now, with over 500 patients looking at really the definitive outcomes of comparing restrictive and liberal transfusion strategies in cardiac surgery. And lastly, our current trial, which is doing the same strategy, but in younger patients, because there seem to be signals suggesting more harm of restrictive transfusion strategies in younger patients, and we're halfway through recruitment. First, before I start discussing data integrity, I just want to define it. And there are various definitions, but just so that we're all on the same page, data integrity really is a process that optimizes validity and accuracy. And I'm going to define validity as what is intended to be measured, including sort of completeness of data and consistency of data, and accuracy, that essentially is the data representative of the true value. Obviously, data integrity is a process, and it's a process that goes throughout the study. I've highlighted or put in bold there before a trial has started, because I really think this is, the best time to include all aspects that are going to ensure data validity and accuracy before the trial has started. So I'm going to give you an example of where our data integrity was not very well thought out prior to a study. This was our first study. And prior to actually conducting the first study that looked at adherence and enrollment, we had done systematic reviews, administrative data reviews, surveys, etc., got funding for the first randomized controlled trial. We had a research assistant that was experienced working at the hospital at the time, who had trained other individuals, such as medical students, who took the role of being the research assistant for that study. And we embarked on that study. As I mentioned, there were 50 patients. Essentially, our data capture was an Excel file. And what I want to highlight for you is sort of the fact that there were 500, nearly 6,000 patients that had cardiac surgery at that time. And we actually, of those patients, only randomized 50 over 3 to 4 years. Certainly not a trial of result that one would want to determine feasibility as well as generalizability of a study. And just want to highlight what is on that table, which was adherence, and it's adherence to transfusion strategies there were three areas that transfusion strategies were supposed to be adhered to. That's in the operating room, ICU, and ward. And as you can see, particularly on the ward, the transfusion strategies are proportion that were adherent were about 50% in the restrictive strategy and 12% in the liberal strategy. Clearly, any kind of adherence, such as what we had resulted in this study, could not be correlated with any outcome. So they're, correlating an outcome with that kind of strategy wouldn't be feasible overall. A couple of other points about this that we learned was that the research assistant wasn't recruiting as many people as we thought. Our medical student took data in the Excel file, and we had to re-abstract all data. And that wasn't so much that it was the issue of the medical student or the research assistant, but more so that the investigators didn't prepare. We didn't educate them enough in terms of what we were going to do with data capture. So based on that, as I mentioned, we learned one thing is really to ensure that we had adequate data capture prior to starting our next trial. And so the first aspect that I mentioned was validity. And there were two components in validity: was completeness and consistency. And I'm going to categorize three areas under completeness. One is completing what is intended to be completed, addressing recruitment, and addressing enrollment. So from the perspective of doing what you intend to do, I'm going to define, and please excuse the simplicity of these slides, feasibility and pilot studies, because we had used the term feasibility and pilot. And I think it's important to ensure that if those terms are being used, then what is going to be collected is going to satisfy what is intended to be captured. So feasibility studies, and I put some characteristics to describe what is collected or what needs to be done in a feasibility study on the left-hand side. Essentially, it's acceptability. So obviously with our adherence, there was no acceptability of the transfusion triggers. And so knowing upfront, and we had an idea that those triggers were not going to be accepted, it's really preparing to ensure that those triggers were going to be accepted, so that showing equipoise essentially, and we addressed that prior to the second study. Demand. I think it was very clear prior to doing this study that transfusion of red cells is for cardiac surgery is the highest patient population secondary to malignant hematology population for utilization of red cells, but demand may not be as easy as what we knew about our study. So for instance, demand may need to be collected in a feasibility study if, for instance, we're looking at platelet transfusion in patients who have received aspirin and had an intracranial hemorrhage. The amount of platelets being transfused for that indication may not be as clear as they would be for cardiac surgery. Implementation. Our study was looking at the areas where transfusion occurred most frequently. That would be the OR, in the ICU, prior to an individual being on the ward. So at all areas, feasibility needed to be addressed in those three areas. Practicality, cost, and resources, not only of blood, but also staff that were involved in patient care and not part of the trial, and the research staff associated with the trial. The adaptation and integration aspects of a feasibility study are more so adapting that trigger in a means that it can be followed. So for instance, in the OR, point of care testing, hemoglobins are done extremely routinely. At what point do you transfuse, and can we ensure that hemoglobin was followed by a transfusion? And integration is essentially, how are we going to ensure that on a chart, individuals are aware when to transfuse? Lastly, expansion. Some feasibility studies essentially are, some feasibility studies, are essentially an expansion of other studies. And certainly our study was. We were an expansion of the transfusion requirements in critical care. We just expanded it to the cardiac surgery perspective. So making sort of a funder aware that that's what you're doing and that's what you're planning to do, that it's already been established, certainly assists with funding for that kind of pilot trial. Pilot studies essentially address performance characteristics such as design, recruitment, and operational strategies. They're intended there to, the pilot study is developed with the consideration that it's going to be very much the same, maybe not identical, as a definitive study with regards to study design, sample size, and data collection. And that the aims that are set out for a pilot study are actually fulfilled, not only operationally, but also with a statistical analysis plan of what will be gained from the pilot study and what will be carried over to a definitive study. So as I mentioned, with regards to measuring, with regards to validity and measuring what you intend to measure, there needs also to be a plan for recruitment and enrollment. And that recruitment sort of starts at the beginning when asking sites to participate in ensuring, and excuse me if these are simplistic notions, but knowing the number of individuals that potentially are at that site and that potentially can be recruited at other competing sites, so that the sample size that is estimated is going to be a sample size that is going to be feasible to collect the data that is required, and ensuring upfront that there will be sites with low recruitment despite what is actually relayed to the investigator, and having a plan in place about how to address that as a study is ongoing, such as frequency of telephone calls or educational seminars, or the assessment of recruitment to ensure that sites are recruiting the similar number of individuals that they had indicated that they would recruit. I put on this slide that we had intended to actually assess recruitment quarterly, but we ended up assessing recruitment almost every month throughout the trial. There needs to be documentation to facilitate recruitment, and this was just sort of an example. And the investigators are the ones, obviously, that are developing that documentation upfront that needs to be put everywhere to ensure that staff around the hospital are well aware of the trial and to maximize recruitment. Enrollment also needs to be maximized. So it's okay to recruit patients, but if they are not enrolled, then that recruitment process really is futile. And so I've separated out recruitment and enrollment overall. And what we tried to do with enrollment, considering there was equipoise about transfusion strategies, is use education. And so we created PowerPoint presentations that were available on YouTube. We had a patient population where there were a lot of healthcare practitioners that were involved that needed to be aware of the equipoise around transfusion to ensure transfusion triggers were adhered to, so that means of having a recorded PowerPoint presentation available meant that whoever was on call at night or during the days, if they could not attend an educational seminar, at least they had a presentation to understand the rationale of that study overall. I think it's also important to know the individuals that are going to be part of whatever network it is for transfusion or any other study, so that all individuals are educated. So from our perspective, as an example of this, even though it was cardiac surgery and anesthesia that were more involved in the trial, there were certainly perfusionists, residents, fellows, and in the intensive care unit, many services that satisfied that umbrella of intensivists that needed to be aware of the trial. So having some sort of educational seminar, whether it be pre-recorded or with some sort of documentation to allow an investigator to actually relay that study, I think facilitated enrollment. Newsletters, I think most studies would include to try to increase enrollment, and having accessibility to frequently asked questions. I think what's critical is really engaging collaborators and to get those numbers of patients, to get the data that is required. And we frequently used surveys. I think we must have surveyed people maybe every 6 months to a year to ensure that if there were any decisions to be made, even though we knew what decisions we wanted to make, to ensure that people felt that they were part of the trial overall, to encourage that collaboration, recruitment, and enrollment. We encouraged recruitment in other studies, so co-enrollment, and encouraged investigators, because of the large sample size, to actually conduct sub-studies of their own. Obviously, when studies are published, not everyone is going to be first or last author or second author, so having sub-studies meant that there was encouragement and then getting authorship in subsequent studies. And lastly, prompt communication. Whenever there was an email exchange, we were quick to respond, easily within an hour for every email question. Lastly, just for this section, is really incentives. And that may seem straightforward, and it doesn't need to be financial. Everyone likes to be sort of first for everything. So we listed top recruiting sites, top adherent sites, and these were included in the letters at all times. In each letter, we would highlight a group and their accomplishments as well, with pictures, to make it seem more that this was a collaborative effort, and it certainly was a collaborative effort. Lastly, what you're seeing on the graph on the right-hand side there is had to ensure that people were aware, investigators were aware. These are the numbers that we've recruited. This is our timeline. This is how we're doing, so that everyone was working together to achieve the sample size that was needed to have this as a successful study. The second was maximizing consistency. And I've defined that as compliance and adherence, finalizing the data to be collected, that development of the ECRF. Just a quick point about this that I won't come back to is a backup plan for the ECRF should always be made, the training of research staff, and then outcome assessments. So first, really compliance and adherence for any study, whether or not compliance or adherence are part of the primary outcome. It's important, whether it be a transfusion trial or, for instance, any kind of either medication or any intervention trial, as if there's not adherence, if there's not compliance, then really there's no correlation between what is being studied and the outcomes overall. So we were quite strict about our adherence and want to follow it in the first, second, and third, and we continue to do so in the fourth trial as well. And we defined it up front and ensured that there was agreement with all investigators. So as an example, what I put on this slide is, if the hemoglobin was less than the assigned trigger, then a red cell transfusion had to be given within 2 hours in the OR, within 12 hours in the ICU, and within 36 hours of the ward. That's what we considered adherent. Anything outside of that was not. We defined for investigators when the protocol can be suspended and when to start, again, to ensure that the numbers were going to reflect the outcomes overall. And again, it's sort of, we created stickers, labels, to ensure that in every place that chart followed the patient. Obviously, it's a little bit more difficult now with electronic charting, but everywhere that chart was with the patient, that individuals knew that they were part of the trial and what those transfusion triggers were. This is also an example of stickers that we placed on charts, or labels that we placed on charts, identifying each one of the transfusion triggers at each place. The more information that was given, the more posters that sites had available, then we were making it easy for those sites to follow those triggers, to improve adherence, again, to ensure that the outcomes were accurate. The most critical aspect, obviously, of any trial is going to be the data that are collected. Even if we knew what we were going to collect with regards to data, and we had an extensive data dictionary, we ensured that the research group reviewed it so that potentially nothing was missed. When we developed the CRF as case report form and EASE CRF, the electronic case report form, we had to develop a number of other documents prior actually to finalizing that. And the first is a data dictionary. And I've given you some examples there of what goes into a data dictionary, is essentially such things as, if consent is going to be obtained, then whoever the research assistant is at the site knows that consent should be at most within 90 days of recruitment. So it's a check. So everything that needs to be done is actually written down. At the top of the page, for instance, we had collected preoperative antiplatelet, anticoagulant drugs. Those should have been stopped prior to the start of the OR. So the dates of discontinuation and the dates when the surgery occurred had to be consecutive, obviously. These are all just checks to ensure that the data were collected appropriately. The last example there is intraoperative antifibrinolytics and vasoactive drugs. And again, same thing, that the timing or the duration of intraoperative, for instance, vasoactive drugs could not have been longer than the OR time. That would have been an error. So when that is defined in a data dictionary so that an individual who checks data is aware of it, it's another check to make sure that data are entered accurately. We had a laboratory ranges dictionary as well. So any laboratory value had ranges according to the country where the individual was, to ensure that whoever was checking the data knew what data to check and what laboratory ranges they had to fall into. Lastly, it's the range checks. REDCap is very good for this, that it allows for a range check. So if there's a laboratory value, there's a range check in REDCap as an ECRF, and so if it's outside that range, it's automatically flagged. When it comes to ensuring that data are collected accurately, that frequency of data checks should really reflect the kind of data that is being collected. As an example, laboratory data, because there's a lot of laboratory data in transfusion trials, it's subject to error. That laboratory data needs to be checked a little bit more frequently. Seems pretty straightforward training of research staff. In TRIX 1, even though we had used research staff that was trained and that was experienced in other studies, there needed to be additional training for that research staff. That may seem obvious, but it's the detail of training is going to be very different, even if it's an experienced research staff that has conducted or has been part of other studies. And what we had tried to do to ensure that the research staff were aware of the details of the study was not only having the research staff obviously review protocols, but actually give the site initiation visits. So when a site is brought on, there's usually a presentation given. We ensured that the research assistant gave that presentation so they had an idea about what was going to be conducted in the study, and they were first to answer questions, so they were able to actually support the study as they went through. They were part of the investigative team, and obviously ECRF training as well. There were tips also developed for research coordinators. Again, so the research team is going to be critical to ensure the data are accurate, and the research team is going to be the ones that are going to gather that data and need to know where potentially there are barriers to data collection overall. So we knew that barriers would be in the OR because a lot is happening in the OR. So it's ensuring that the research assistants were going to be there to remind, for instance, the anesthetist perfusion before the OR and after the OR. And the more that they were present, the more the data would be collected and collected completely, as opposed to having missing data. We ensured that there were other sort of tips that were added on to a tip sheet that were circulated to all sites, such as, maintain consistent presence, flagging paper charts, really stepwise approach to ensuring the data were collected completely. Lastly, it's accuracy of the outcome assessment. For what I learned along the way was the outcome assessment really needs to be clear. And sometimes that's very difficult for some studies, but if possible, it's making it very black and white, sort of as mortality. It either occurs or it doesn't. The outcomes that we had collected at the time were all that could be associated with anemia associated hypoxia and were very objective. Mortality, renal failure, that is dialysis, acute myocardial infarction, stroke as evidenced by imaging. So there wouldn't be any chance that there would be any incorrectness in defining what that outcome was, and also seeing all that data and having it adjudicated ensured that it was accurate. Transfusion trials obviously can't be blinded for the most part, and so masking clinical outcomes, meaning that those who are adjudicating those events aren't aware of what trigger group those individuals were part of would then reduce the amount of bias in determining whether the outcome occurred or not. I think, Jacob, when you asked me to do this, what was of most interest is really data verification or accuracy to ensure that the data inputted was going to be accurate. And this took a considerable amount of time and again was done upfront. Generally speaking, pharmaceutical or industry studies, because they do have a lot of funding, do on-site source data verification for all data. That's quite expensive. So it's essentially having an investigator going to a site and looking at all the data that was entered and ensuring that it matched laboratory data, whether it be on a database or paper charts. With COVID came the onset of remote source data verification for all or part of a sample, and certainly that is much more acceptable now. The third means of doing that is central statistical monitoring, and this is what we did in our study because it was a CIHR funded study, and so on-site source data verification, we obviously didn't have the funding for that. And for remote source data verification, we were pretty sure that our data verification was going to be accurate, and we were concerned partly about remote source data verification that we may not get the data that we require accurately. So we decided to use central statistical monitoring. And these are data checks. And I'll go through this in the next few slides about what was done. And it ensured that the data was entered was of high accuracy. Some sites will use central statistical monitoring as well as source data verification remotely. So central statistical monitoring occurs at the participant level and also occurs at a center level. So at a participant level, as an example of what happens, is the dates of randomization. So any database is going to have the date of randomization. If those dates of randomizations are occurring on weekends, then it's likely that there is an error there. It's very unlikely that patients are going to be randomized on a weekend. Most of them are going to be randomized during the week. So that would be a check that we would include. At the central level, there are several statistical means of looking to determine whether or not data are entered accurately. Most of these are comparison of means and looking at variation. And most are done graphically, in addition to some of the statistical testing, such as means, variances, standard deviations, and using statistical significance, that is a p-value, to see if there is a difference. So when we're looking at means, plots are developed to visually identify centers with too little or too much variation to assess these differences. So the plots can be all of histograms, box plots, and Vineland plots, all of these, because they really allow you to see the data a little bit differently. Data are plotted on the same plot for all centers to look at variability. And it's really, when looking at these data, it's plotting out these data that are going to be subject to errors. As an example, the hemoglobin concentration, because it was going to be measured so frequently, was one of the measures that we used for central statistical monitoring. So I'm just going to give you an example of the statistical monitoring plan that we had conducted for the TRIX3 trial. So it was 5,000 patients and it was about 73 centers. So we couldn't actually go to the sites. We did some remote data monitoring for about 1% of the patient population, but the rest was statistical monitoring. So as an example of this, so this is an example of the hemoglobin concentration measured. What you see on the first table is the number of observation, and then a dot plot followed by a histogram to show the dispersion of hemoglobin concentrations to give us an idea if each center had similar dispersions overall. 4.1.2 here is a summary by site, so the means, the ranges, and the standard deviations. What you're seeing here is something called the the last digit by site, and it is well established that there are some sites that might enter data in inaccurately, and when they do so, that last digit becomes the same, or that last digit is a zero. So this is looking for dispersion. And if you notice on the table right below it is really the statistics for prevalence of that last digit to see if there is a difference overall. And if it's statistically significant, then we went back to those sites to determine whether or not there was an error in data entry. Such things as the violin plots and the box plots are also very useful to look at dispersion according to sites. And then there was a comparisons of means and variance. How would this look different if there was a problem with data being collected? And what I'm showing you on this slide is really, it's an example of, these are white blood cell counts that were collected, size 1663, look like there's a difference, but site 68, it looks all the same. And so that would identify data entry errors. On the right-hand side is really the outliers. As you can see in red there, I hope it's easy to see, there's sort of, when looking at the data, it's all quite similar, and then one outlier. On the bottom graph here, several outliers for a specific site, suggesting obviously a lot of data inaccuracy overall. So these data were done twice for the TRIX-3 trials. One was done after about 50% of patients were recruited, and one was done at the end, again, to ensure that data were accurate, and we went back to centers whenever there were any accuracies that were detected by central statistical monitoring. There are other means of detecting inaccuracies, and I've only listed a few on this slide, such things as the digit preference, like I had mentioned previously, the rounding up of a number, too few or too many outliers, too little or too much variance. There are peaks when there shouldn't be peaks, and the data appeared skewed. This can be done with several variables at the time that shows. Similarly, for instance, several variables would be association between, systolic blood pressure and diastolic blood pressure. There may be too weak or too strong of a correlation, and in those situations, the data would have to be checked as well. Repeated measurements, hemoglobin was certainly a repeated measurement that we had to look at, and that variances in repeated measurements can be determined by looking at duplicates and interpolation essentially is inserting a value when the value actually did not exist. And lastly is calendar time, as I mentioned previously. I'm going to stop there a few minutes early just to say that validity and accuracy of data are really ideally planned prior to trial initiation, and then minor sort of tweaking of that occurring through the trial, but ongoing assessments of recruitment, enrollment, statistical monitoring really is intended to ensure that the data are completely collected so that outcomes can be correlated adequately. I just want to leave with a last point. Overall, a clinical trial database can never be completely free from errors. Really, monitoring of trial data is used to minimize errors as much as possible. And I'll stop there. I want to acknowledge all the individuals that participated in the TRIX trials overall. As I mentioned, there were 73 centers, 11 different countries, and without whose support, we really could not have been successful in maintaining a high adherence. We had an adherence rate of 90% to correlate transfusion triggers with outcomes. I'll stop there and thank you for your attention.
Thanks so much, Nadine. Very helpful. And again, every time I hear you sort of discuss this, I kind of wish, like, God, I wish I had come to you for help, when I was designing and doing my own trials, and then sort of very painfully and laboriously going through and doing that source verification. Can I ask, though, the statistical assessment of the noise in the data, that looks like a very sophisticated undertaking. Is that something that you did, or is that something that requires a statistician? How did you go about that?
So it requires a statistician. We had a detailed discussion about what we were going to do for statistical monitoring. This was just for hemoglobin. We actually did it for many other values. So we identified values. That the one paper that is referenced on that side by Bice and colleagues is really a very, it was very informative for us. What should be collected. So things like repeated measures, things that, items that would have high variability, we ensured that we were going to use those variables when we were going to do central statistical monitoring. It definitely needs a statistician. Just sort of, it was about 100 pages of graphs to review for each one, each time that we actually reviewed these data. So it was very helpful having a statistician who just specifically looked at the statistical monitoring.
And had you developed the data verification protocol before you started collecting the data, or was it only after you had finished the trial that you sat down and said, okay, what are we going to do with all this?
No, before.
Even before. Okay.
Yeah, we did everything before. I think the difference between one, I learned a lot from one, and so when it came to two, everything was done. The data dictionary was done beforehand. The laboratory ranges were done beforehand. We didn't have REDCap in the previous trial, and I can't recall what the database was, but it was very easy in helping us input ranges and identify those that were coming out of ranges to ensure that they were checked appropriately. And then the statistical monitoring plan also was done prior to actually even enrolling the first patient.
Yeah, it's very helpful. I'm not sure if anyone else has any questions, but if not, I was going to actually call out Jeannie about just the Concord 1 trial, and you've been involved in a few very large studies. There was uh, fibers and FAIRs. What was the approach you took to this issue in those trials?
Well, I can tell you what we're doing right now because we're running the FAIRS 2 study. And basically, like the amount of queries that go back to the site for every single test, every single outcome is just a massive amount of work. In addition to the monitors going in to check all the primary outcomes, like all the key important outcomes for the trial, checking every single patient, and then checking a smaller proportion for every single data element in there to let us know that a site has a problem or doesn't have a problem, so you can escalate the amount of monitoring for extra sites. It's just a massive amount of work. And every week we have a meeting and we go over number of queries per site that are still pending. Like for the first 100, the second 100, the third 100, it's just a massive amount of work to track the data elements in the trial to make sure you have really good quality data at the end of the day.
And are you doing the same kind of central statistical modeling that Nadine was describing?
About checking for digit errors?
Just looking for sort of like statistically significant outliers as a way of indicating that a site is maybe not super solid.
No, we've never done that before. We basically use the monitors to look for those flags. We've been lucky so far within the Canadian context not to have that problem arise, at least not yet.
And could I ask maybe you and Nadine this? Best practices, I've always thought, when you're doing data collection is to put it directly into an electronic database, like, right from the source document you're looking at into your research database. But realistically, that's kind of hard to do, so people have a piece of paper that they'll write something down on, and then later they'll transcribe that into the database. And I've always kind of worried, does that not double the number of checks you have to do? Like, you have to check the electronic against the paper, then the paper against the source. How do you avoid that? Because the error is going to occur at any step of the transcription process, and the more transcriptions you're doing, the more errors you're going to have.
So, sorry, Jeannie, go ahead.
I was just going to say, I'd like to hear Amy and Harley's take on that because we've had a lot of conversations about the paper case report form. The problem, like we've always had, is it's a lot of work to do it directly. And it's nice to have the full capture and then you do your data entry. And also you can have a different person do that data entry and then somebody cross-check it. But Amy, Harley, your take on the duplicate paper case report form?
I think doing, I don't know, per se, like doing it on paper first. Sometimes I find it actually more difficult to transfer directly from a patient record online. But the problem with that is when they come back with queries, you have to update both the eCRF and the CRF. So that also creates more work.
Nadine, how did you go about this with the TRIX trial? Was there did you have paper CRFs or was it mostly electronic data entry?
It's really dependent on the site. So some of them definitely were electronic, and some of them had to, and as you indicated, when you transcribe on paper and then back, there's a higher chance of error, but unfortunately, that's all that could be done. I mean, there were some things that we did in other studies where, you print out the data. So it's not so much written on eCRF, you print it out and then enter it, but obviously ensuring that it's discarded appropriately. I think it might be a little bit easier with Epic these days because Epic is so accessible on phones that you can then enter data into an eCRF a little bit easier.
Okay. Could I ask as well, just in terms of the timing of the data verification, when you're sort of doing, the just going in point by point, going, even if you're just doing kind of like the high hazard or like high meaning, data points, like a hemoglobin level or whatever. When you're doing that sort of direct assessment of each point against the source material, it's super slow and laborious, and it kind of makes sense to kind of do it as the trial is proceeding, so you don't have this massive mountain of data at the end you have to go back, and also you can kind of like nip things in the bud as you're seeing them. That's certainly the approach that I've taken, is like do the data verification as you're doing the trial. But with the central statistical modeling, that would seem to be kind of harder, right? Because like, the less data you're analyzing in your models, the less statistical power it has. Like I would imagine you'd be able to spot those outliers a lot better at the end of the trial because you've got all your data in. So how did you time that approach, like that central modeling approach? Did you do that, sequentially during the study, or did you kind of wait until you had all the data at the end and then you ran the whole thing?
So we did it twice, 50% after 50% were enrolled, and then at the end. But we also had the data checks going through, right? So that the ranges were inputted, the queries were addressed all the time. So this was in addition to the data checks queries. And then we had a proportion that, at the beginning of the trial, we did source data verification, obviously not in person, but electronic as well. And there were, like, the database that was developed was timed. So there were times of entry to ensure, again, that additional check of if this was a hemoglobin done at this time, then the transfusion had to be following that hemoglobin again. So another data verification step to make sure that everything was occurring consecutively.
Okay, if I could just make one more question, just for the benefit of the new researchers, the people who are just starting out and have an idea for a trial, and don't know how horrendous this whole part of the process is yet. What advice would you give them? Like how, in terms of making sure that, they're not left with a giant Excel database full of junk, what would you tell sort of a new investigator? You're not someone who's got lots of pharmaceutical funding or a giant CIHR grant, but just, their local, $20,000-$30,000 grant, to do like a 3-month study. What advice would you give them about data integrity?
So I think several points. I think one is ensure you've got a team that wants to work together, and is going to participate in every aspect of what you do with regards to your data gathering. I think the second is sort of what they say. It takes, like, if you apply, and I'm sorry, I'm going to use the example of a clinical trial. If you've got funding for a clinical trial, the assumption is it's going to take you at least 6 months to start. Use that 6-month period to develop all these documents, that you have all the range checks, all the laboratory values, what you're planning to do for your source data verification upfront before you even get sites on board, to start getting that enrollment process. You know, it's the sort of the step after you get funding, it's okay, I'm going to apply to REB to start that ethics application because it takes so long to get approval. But I would actually suggest delay it until those aspects of data collection are finalized.
Like, don't even submit to REB until you have your data integrity protocols all figured out.
Everything figured out in the data dictionaries, the ranges, etc., and what's going to be done to ensure the data are accurate.
And that took, how long did that take you to do all that for the TRIX trial?
Easily 6 months.
6 months. Wow, that's a lot of prep just to get to an REB submission. But that's how you get a New England Journal publication, I guess. So, well, that's fantastic. I don't know if anyone else has any questions in the audience, who's here, who's signed on. All right, if not, I guess we can finish up a little early, and we can meet again next month. And I guess for those who are going to Montreal for the CTTG meeting, then we will see each other in person. Okay, thanks everybody.